clinical trial of fluid infusion spray for pediatric diabetic ketoacidosis. Definition: Diabetic ketoacidosis in children may cause brain injury ranging from mild to severe. Whether intravenous fluid contributes to this injury has been debated for decades. Early theories to explain diabetic ketoacidosis rely brain injury such as rapid administration of intravenous fluid reducing serum osmolality, which result in brain seven.
Hello, in this video we're going to talk about diabetic ketoacidosis. This is an introduction and overview. It is important to know that diabetic ketoacidosis is a medical emergency, especially in type 1 diabetic patients. But it is known that it can also occur in type 2 diabetes. As the name suggests, it has to do with acidity. So there's increase in acidity in the blood, essentially. The signs and symptoms of diabetic ketoacidosis is nausea, vomiting, polyuria, polydipsia, weight loss, hyperventilation, known as Kussmaul's breathing. Now, diabetic ketoacidosis doesn't occur out of the blue. There's usually some triggers. And these triggers, these etiologies, it can be remembered as the 5 I's. The 5 I's are infection, intoxication, inappropriate withdrawal of insulin, infarction, and intercurrent illness.
Application is news. Children were eligible for trial enrolled in the were between 0 and 18 years of age and reside and diagnostic of diabetic ketoacidosis take by nurse.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over diabetic ketoacidosis, also called DKA. This video is part of an endocrine series that I've been doing on the diabetic patient. So if you haven't seen those videos, a card should be popping up so you can access that link. In those videos, I've been talking about the pathophysiology of diabetes, the pharmacological aspect of it, and all that. So what I want to be doing in this video is I want to be going over DKA, specifically the patho, the nursing interventions, the causes and the signs and symptoms, and I want to hit on the things that you need to know for NCLEX and for your nursing lecture exam. Now in the next video, I want to be going over the complication that is similar to DKA, which is hyperglycemic hyperosmolar non-ketotic syndrome, which is HHNS. And then I want to take it a step further in another video, and I'm going to compare DKA versus HHNS. So be sure to check out those videos. Now after this video, be sure to go to my website, RegisteredNurseRN.com, and take the free quiz that's going to test your knowledge on the patient with DKA, and a card should be popping up so you can access that quiz. So let's get started. Okay, first let's define what DKA is. What in the world is DKA? DKA is a life-threatening condition that patients with diabetes mellitus can suffer from. And what it is, in a nutshell, is that there is absolutely no insulin in the body. And insulin plays a role in using glucose. And glucose fuels our cells, but the body can't get to the glucose. So it starts breaking down fats for energy. And when it breaks down fats, it releases ketones. And ketones in the diabetic patient can cause major problems. So what you're going to be seeing in this patient, the three things, I would remember this because everything else will make sense. You're going to be seeing hyperglycemia, you're going to be seeing ketosis, and you're going to be seeing acidosis. And
Pros and cons. Neurological state disorder during and or within the first of the treatment for diabetic ketoacidosis, short-term memory during the treatment of diabetic ketoacidosis. During the course of the trial, the gas-blood coma scale score decreased to 3% of tested episode.
The purpose of this video is to provide general information and education about the care of a critically ill child. It is in no way a substitute for the independent decision-making and judgment by a qualified healthcare professional. The information contained in this video should not be used to make a diagnosis or to overrule the advice of a qualified healthcare provider, nor should it be used to provide advice for emergency medical treatment. Management of Diabetic Ketoacidosis by Dr. Michael Agus. Please note that in this video we will be following the guidelines used at Boston Children's Hospital. Some of this information may need to be modified based on the equipment, guidelines, and practices in place in your institution.
Hi and welcome. I'll be speaking today about diabetic ketoacidosis, or DKA. My name is Michael Agus. I am a pediatric intensive care doctor and a pediatric endocrinologist at Boston Children's Hospital. I'm the director of the Medicine Critical Care program here at Children's and an assistant professor at Harvard Medical School.
Hyperglycemia.
Why does one get hyperglycemic in DKA? Why does the blood sugar go up at all? Well, it's really the same reason you get hyper-anything-emic in any clinical situation. It's some mismatch of increased ins and decreased outs. So what are the increased ins of glucose into the bloodstream? Well, one major one is the one that patients are doing at home. What are they drinking at home? In general, they're drinking Pedialyte or juice or some dextrose-containing fluid, and they don't realize that they're driving their blood sugar higher and higher. The other actor that's adding glucose to the bloodstream is the liver. The liver believes the blood sugar is extremely low because it can't get any glucose intracellularly because of the insulin deficiency. And so it turns on gluconeogenesis at full throttle. And of course, that's also what produces the ketoacidosis, the lipolysis, freeing up those circulating ketones, free fatty acids as well. Now, where
is split in Ecuador? In the Francisco de Casa Bustamante Children's Hospital, between January and December, the diagnosis of diabetic ketoacidosis of patients corresponding to children 5 years old, on which were 10 years old.
So you have type 1 diabetes. It's something you're going to manage, mostly with insulin, a hormone your body doesn't produce when you have type 1 diabetes. By now, you probably know how and when to give yourself insulin. And if you have an insulin pump, you probably know how to maintain it. But do you know how to tell if something's not working? That's what we'll be looking at. You eat carbohydrates to fuel yourself with energy. Your body breaks down the carbs into sugar, which then goes into your blood. Think about it like filling up the gas tank in a car. When you eat, your body stores the carbs to use as energy when you need it later, like filling up the gas tank. Insulin is what opens the tank to let the gas in. As someone with type 1 diabetes, you don't produce insulin naturally, so the sugar doesn't get to where it's supposed to be, which is why you take insulin. If you're not getting the insulin you need, the sugar you eat stays in your blood instead of being stored in the tank. When this happens, your body won't have the fuel it needs when it needs it, and your body will seek out alternative sources to break down into fuel. One of the first sources it looks for is fat. Except when your body breaks down fat, it leaves ketones in your bloodstream that make your blood acidic. Together with high blood sugar, acidic blood from the ketones can make you sick and put your body in a state of diabetic ketoacidosis, or DKA. And DKA is really, really serious. It can even be fatal. The most common reasons for DKA happening are developing type 1 diabetes, missing taking your insulin, getting an infection, and malfunctioning equipment.
Conclusion. Neither the administration rate nor the sodium chloride content on intravenous fluid significantly influence the neurological outcome of diabetic ketoacidosis in children.
Brain injury is an uncommon but important complication of pediatric diabetic ketoacidosis. One hypothesis has been that rapid infusion of intravenous fluids during treatment causes a reduction in serum osmolality, leading to brain edema and injury. Current recommendations based on retrospective studies suggest using a slow infusion of isotonic fluids. In a multicenter randomized clinical trial with a 2x2 factorial design, investigators evaluated 1,389 episodes of diabetic ketoacidosis in 1,255 children from 13 urban emergency departments in the United States. The children were assigned to either a rapid or a slow infusion strategy, and all received an initial bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram. The rapid infusion group received an additional bolus of 10 milliliters of 0.9% sodium chloride solution per kilogram, and a fluid deficit of 10% of body weight was assumed, of which half was replaced over the initial 12 hours and half over the next 24 hours. The slow infusion group did not receive an additional bolus, and a fluid deficit of 5% of body weight was assumed, and was replaced evenly over 48 hours. Within each infusion group, children were assigned to either 0.45% or 0.9% sodium chloride solution for replacement after the initial fluid boluses. All other treatments for diabetic ketoacidosis were identical. The primary outcome was a decline in mental status, as defined by a Glasgow Coma Scale score of less than 14. Scores were obtained hourly for 24 hours or until the resolution of diabetic ketoacidosis. There was no significant difference in the rate of the primary outcome between the rapid and slow infusion groups, or between the 0.45% and 0.9% saline groups. Serious adverse events were rare and occurred with similar frequency in all groups. The authors conclude that neither the rate of administration nor the sodium content of intravenous fluids significantly influences neurologic outcomes in children with diabetic ketoacidosis. Full trial results are available at nejm.org.